The law that we're using for death registration was enacted in 1973. Yeah, so previously registration was not compulsory. It was restricted to a particular population group. But from 1973, it was made compulsory so that every death that occurs within the boundaries of the Republic of Zambia must be registered. And so from that time, the system had been passive because you needed to wait for an informant to come to the registration office to come and inform the office that a death has occurred. But what is happening currently because of this initiative is that we are capturing the occurrence of these events at the point of occurrence, which is the health facility. So it has brought an active side to the system.
Zambia had, before the initiative, had one of the lowest registration coverages, especially on deaths, and mostly because of the non-facility deaths that go unregistered. So the law in Zambia requires that for death to be registered, it has to have a cause. So when we talk of Zambia having one of the lowest registration coverages, especially on deaths, was because of that actually caveat, because most of the deaths would not have a cause, so they cannot officially be registered. So verbal autopsy is trying to bridge that gap, especially for deaths that are not happening in the health facility. Again, to say in the law of Zambia, the only person who's supposed to certify a death is a physician. We have a very few number of physicians. The country estimates over 1,800 physicians.
The value for verbal autopsy in Zambia is that we're able now to get health information on probable causes of death for community deaths for which we did not have before we started verbal autopsy.
We have evidence to show that there is a positive impact in two main areas. The first one being improving coverage for death registration, and the second one is being able to generate usable vital statistics from civil registration, because previously we were not able to generate that because of one, low coverage, and secondly because of a high number registered without a cause. But today we have evidence to show, in the sense that we have a number of reports that are written showing accurate vital statistics that are comparable with the other vital statistics from other sources like the survey reports, as well as the information from the health management information system.
The importance of also integrating the two data sets from MCCOD and as well as verbal autopsy is that we want to see community deaths. What's the pattern of community death? Are there any deaths that are unique to the community which probably are not in the health facility? Or could it be that the people that die in the health facility could be dying from other conditions in the community? So integration of the two will also enable us to look at the patterns of the cause of death for the two and see where there could be special cases which would inform policy.
You realize that when you do a comparison with the data that we have with the cause that is determined by a physician and the causes that we are getting from verbal autopsy, there is a very high correlation which gives value to what we are getting from verbal autopsy. Really, there are very few surprises that would make one try and question the results that we are getting from verbal autopsy.
We initially are piloting verbal autopsy in Lusaka, and we have two pilot sites where we are piloting verbal autopsy. So with some of the preliminary results that we have, we've been able to see that we were missing quite some health information from the community for which we did not know what those community deaths were. But now with implementation of verbal autopsy, we're now able to generate some probable causes of death from community deaths?
So far, for Lusaka, we can say with the number of deaths that are being captured in the health facilities, for those deaths that occur there, and those deaths that we are getting from the community deaths, we actually can estimate that we've improved our coverage for Lusaka greatly. Probably we can be talking over 90%. The surprises are there. Some of the things are already known. For example, in most of the causes in the urban areas like Lusaka are road traffic accidents. But you are also seeing deaths that probably you hear on news, but they are not documented, like homicides, gunshots, which probably you might hear, but they are not collected in a much more systematic way. And suicides too, which are really very sensitive, like in most African countries, but through the verbal autopsy system, they're coming out. And I think that will have an impact, especially for public health. If the policymakers can see this, at least there's an official way of collecting this information. What I would say is also important with the initiative is that we haven't only concentrated on verbal autopsy, also understanding that a lot of deaths that are happening in the health facilities are supposed to be certified by physicians, but the quality of certification has not been good. So what the Data for Health did was to train physicians. And how did we train these physicians? We came into an understanding with the Zambia Medical Association, and the Zambia Medical Association now took over this training, and they've been training physicians all around the country. And we are seeing positive results because now when we review the quality of the certification, we've seen a lot of improvements. So I think that has been a very huge contribution of the project to Zambia, so to say. And just going further, we are now introducing tools, learning tools like e-learning tools, which we can use to train physicians for their CMEs, and also physicians who are in training. So we are trying to introduce these tools and incorporate them into the medical school curriculums, so that physicians who are in training could start understanding the importance of knowing how to properly certify a cause of death with the WHO international standards. Yeah. So that has been a huge contribution of the project.
I think another huge contribution of the project is that we now have a well-established morbidity and mortality coding center. So once the doctors certify, the deaths that are notified and registered come to the Department of National Registration, Passport and Citizenship, which is the Civil Registration Authority. Zambia now is able to translate what the doctor has certified into codes, alphanumeric codes. ICD-10 is what is currently being used. And from the ICD-10 codes, we're able to produce mortality statistics. So I should add to that we've also been able to automate the coding process with the introduction of IRIS. So so now for all deaths that come with an MCCOD, they are coded to ICD-10. And apart from using the manual, we've started using the automated system. IRIS now enables us to code more certificates, has increased efficiency, and we're able to process more of the medically certified certificates. So this really has been a plus from the initiative.
In terms of capacity development for officers under the Civil Registration Authority, so the coming in of this project has really helped to build capacity of most of us under the civil registry. So as Mr. Mongo has mentioned, we now have qualified coders who are able to handle coding for most of the MCCOD cases. But also from the admin side, a number of officers have benefited greatly in terms of capacity building, such that we now have skills in-house that are able to play a part in terms of generating these statistics, and also interpreting the UN recommendations in terms of improving the civil registration system to be able to produce results that are internationally comparable and usable.
So we have this bulletin, the public health bulletin, which is is being run by another arm of the Data for Health, that is the data use part. So ideally is to publish public health data in a format that could be able to communicate to policymakers. So they can use data, health data from health facilities, including data that is coming from the civil registration and vital statistics. So I think it has been a very good vehicle to publish, disseminate CRVS data. For example, if we want to know the proportion of people who are dying from road traffic accidents, for example, from the VA, we can write a policy brief and then we can use that public health bulletin to inform people. Yeah. So that's, I think, has been an important part of the initiative. So we've married each other quite well.